who had a severe case of COVID-19, but also highlighting his rehab course and kind of what all entailed with that. So, alrighty. All right, so just going over some quick objectives here. So going to go over some disclosures, kind of go through the numbers of COVID-19 as well as just the spectrum of illness. Going to talk a little bit about my specialty, which is PM&R and physiatry. And then kind of go through our patient's case, both his acute hospitalization, but also his inpatient rehab course. Going to briefly touch on a couple outside cases and then just kind of close it up from there. So some disclosures. Again, I'm a third-year physical medicine and rehabilitation resident. I'm currently in year 3 of 4 at the University of Toledo. What I am not, I'm not an intensive care doctor. I'm not an infectious disease doctor, not a lung doctor, an ER doctor. I think obviously with each of those specialties, they're going to have a little bit different take, certainly a little bit more expertise in each of those areas. But I will touch on each of those a little bit, but for tonight, I kind of wanted to focus from the rehab standpoint and how our patient progressed from there. So just kind of going through COVID-19 by the numbers. If you haven't had this, hitting your head already through CNN or Fox News, I think just today, I just updated this slide earlier this morning. I think today we just hit over 150,000 deaths in the U.S. and globally, I believe we're fairly well over 650,000 so far. So when you compare those to other illnesses and diseases, compared to the seasonal flu of last year, the CDC estimates somewhere between 24,000 to 62,000 deaths with that. I know you're probably looking at that range is quite large. The reason why the CDC provides that range is there's different states record different ways as far as how they record an influenza death. So there's not a set way for all 50 states in the country. So that's why that figure is the way that it is. Now, when you compare it to other conditions like stroke, in 2017, there were just about a little over 146,000 people that passed away of stroke, and a little over 121,000 that passed away of Alzheimer's disease. And then when you compare it to other global events, such as 9/11, 9/11, we lost just under 3,000 people, and with the Allied invasion into Normandy, there's an estimated loss of around 10,000. So, what does all that mean? Certainly, there's, I think, a great deal of debate as far as the numbers, as far as U.S. deaths, as far as U.S. cases. But, regardless of all that, I think it's still a significant number. Even if you want to debate if that true number is 120 or let's say 130,000, when you compare it to other illnesses, and even though, 9/11 and the Allied invasion, those were single-day events, those events in particular, I think, hold a very deep meaning in most people's hearts. And certainly, I think most people can recall where they were, when 9/11 happened. And again, when we compare it to stroke and Alzheimer's disease, these are very common illnesses. So basically, I think the bottom line with this is it's something significant and it's something that, needs to get our attention. So when you look at the degree of severity of COVID-19, we largely base this off of a study done in the New England Journal of Medicine, a very reputable journal here in the United States. And this is based off of around 74,000 cases of COVID-19 that were seen in China. When you look at the spectrum of illness, obviously, as I'm sure most of you are well aware, that there's a very wide spectrum of how people present. 80% of cases, so about 4 in 5, are going to have mild symptoms. And I put mild in quotations because, mild can include anything from asymptomatic carriers to having the worst flu you've ever had in your whole life. But basically, bottom line is that regardless, those symptoms aren't going to require you to go to the hospital. Now, do some of these individuals, are they going to have reduced lung capacity, lung function? Are they going to be deconditioned because they had this virus for a week or two? That's a possibility. But again, the main point is that they're not going to require hospitalization. So As far as 14% of cases, these are going to be considered severe. This is going to require hospitalization. So some of the symptoms that people are going to experience, the big one would be hypoxia, shortness of breath, increased work of breathing, something we call tachypnea, where basically the body is trying to compensate for oxygen deficits and is trying to breathe at a faster rate to still maintain normal function in the body. So you are able to do that for some amount of time, but eventually your body will tire out. So it's something that needs to be corrected in a short amount of time. Tachypnea is kind of like a sprint, but not quite like a marathon. So yeah, you can do it, but again, it's short-lived. So the other major component is if you're coming to the ER, you experience shortness of breath, and the ER doctor decides to do a CT scan or a chest X-ray. If you have over 50% lung involvement, that would be considered severe, and that makes sense. We would want to admit you and kind of monitor you and see how you progress. So sorry, I jumped ahead there. 5% of cases are considered critical. This would be considered respiratory failure. Also includes multi-organ involvement, sometimes shock. So shock would be where you don't have a high enough blood pressure to sustain adequate blood flow to the rest of the organs in your body. And respiratory failure, a perfect example would be you had that tachypnea, you were breathing really fast. Now you're tired out, your muscles are fatigued, and they can't maintain the oxygenation that your body needs. So we need to, possibly put you on a ventilator and have a machine do the breathing for you. And then 2.3% of cases are fatal. And again, like I've said before, there's some debate as far as where that true number really lies. There was a recent study published just a few weeks ago in Lancet, which is a major British medical journal. And many of the experts thought the true range was somewhere between 1 to 2%. So kind of taking a step back, and again, kind of explaining my role a little bit. Physiatry resident or PM&R resident, that's physical medicine and rehab. That individual is a medical doctor or doctor of osteopathic medicine, in my case, specialize in physical medicine and rehab. So in particular, it take a little bit extra training in areas of traumatic and non-traumatic brain injury, also spinal cord injury, polytrauma. So that typically that might include like someone who's involved with a motor vehicle accident, maybe multiple fractures, maybe multiple organs damaged. And then on an outpatient basis, help manage neuromuscular conditions, but also sports medicine and pain management. And really one of the big mantras as a PM&R doctor is to treat the whole patient. That's kind of what I like here, this mind, body, spirit. And really from our standpoint, the focus and the goals are a little bit different from most other areas of medicine. So the focus is less on diagnosis and more on function. And oftentimes, when we're consulted in the hospital, the patient's already been there for a number of days. Certainly in the case of COVID, they have their test. Maybe they've been on antibiotics or a certain amount of treatment. They've been managed for a number of days, and that's great. And they have that plan. But they can't get out of bed because they're too weak, or they can't get in and off the toilet because they're too weak. And I think that's where we really step in and say, okay, yeah, we know the diagnosis, but these limitations are going to prevent them from getting to discharge to home. And that's kind of where we take over. So kind of expanding on there a little bit. So a PM&R doctor manages a team of professionals with a patient-centered approach. Those professionals include therapists, but also pharmacists, nursing staff, which is specialized in acute rehab, and case management as well. So kind of briefly touching on each of those individuals, physical therapists, they're going to help with generalized full body movements, things like going up and down stairs, walking with a cane or a walker. Occupational therapists, a little bit more in the nit and gritty. They help with what we call activities of daily living. So that would be things like eating, grooming, bathing. Speech therapy, that's a little bit of a misnomer. Certainly they help with speech and they're great with that. But they also help with cognition and memory, which is vitally important with somebody who's had any kind of brain injury. We have pharmacists, pharmacists, nursing staff, case management. They're all kind of have a slant towards inpatient rehab and kind of knowing what's likely to come up. And really case management too, they're especially helpful with trying to figure out discharge planning, trying to figure out, okay, yeah, the patient can leave acute rehab, but maybe they need therapies when they go home. Maybe they need a ramp if they have 2 steps to get into their house. And so they're really great for those kind of things. And as a whole, our field is relatively small, not well known even within medicine, not only, within medicine, but also outside of medicine. And despite that, I think there's a growing knowledge that what we do provides significant benefit to patients. And I think you see that by the anticipated growth rate, by about 17% by 2025. So I think there's, again, medical professionals out there, my colleagues and other individuals that are starting to learn and understand that what we do provides significant benefit for patients. Alrighty, so what's the role of physiatrist in COVID-19? Again, kind of expanding on what I was saying earlier. So, from an acute hospitalization standpoint, we have, or the patient's now medically stable. Their vital signs are stable. Their lab work is looking better. Their imaging is looking better. But, in the case of COVID-19, what is often the case is, yeah, but they've been in the ICU for a very long amount of time, or they've been in the hospital for a very long amount of time. So, yes, they're medically stable, but they're deconditioned and they can't go back to home in that state. So, they lack the physical strength to perform the day-to-day tasks at home. They might lack the coordination and balance to do those tasks. And then in addition to that, knowing that, COVID-19, there's extensive, with extensive infection, you might have multi-organ involvement, certainly expected extensive involvement with the lungs, that there's enough medical complexity where 24/7 physician oversight would be beneficial for the patient, at least for the course of a couple additional weeks. Alrighty, so diving in now to our particular patient. So our particular patient, he presented to an outside hospital on March 20th, was having some difficulties with breathing, shortness of breath. In the ER, they ended up doing a chest x-ray and a CT scan, and the radiologist read it as evidence of pneumonia within multiple lobes, but really the key one that you really don't like to see on any imaging study that you order is findings consistent with COVID-19. So that definitely raises the hair on the back of your neck. And then they ended up doing a COVID nasal swab, and that was positive. So the image on the right, this is a CT scan, not of our patient, but of another individual with COVID-19. And as you can see here in the arrows, if you can think about how the patient would have this test done, you actually are laying in a tube, and that this is actually the left lung and this is the right. And that lighter parts of the images are solid or fluid and darker parts are air. So this would be the spine right here. If you think this is outside of the patient, this is obviously air. And again, these are the patient's lungs. And again, darker would be air. This would be normal lung here. But then when you see in the peripheries, this would be some fluid collection. So definitely darker, and certainly on this left side of the lung, that would be something that would come up. So unfortunately, 3 days after the patient was admitted, he was intubated due to worsening breathing, and he was transferred to the ICU. So the ICU course for our patient, certainly extensive when you look at that list. He ended up developing what's called acute respiratory distress syndrome, basically where it's an acute response of significant inflammation of the lungs. And the mortality rate for that is about 40%. So there's some debate as to where that true number lies. In teenagers, that number is closer to 20%. In individuals over the age of 85, it's over 60%. So either way, those are not very good odds. Certainly not odds you'd want to. Certainly not odds you'd want to take to Vegas. But even in addition to that, with ARDS, there's some studies out there that show ARDS with COVID-19 behaves in a different manner than ARDS from other pulmonary causes. And that some of the protocols that we're using for how we normally treat ARDS isn't responding as well when we treat COVID-19 ARDS. So definitely concerning. Again, I don't want to dive too much into that because I'm not the ICU doctor, but basically it's a significant event and significant inflammation, which is affecting the patient. So in addition to that, he developed acute kidney injury and briefly required hemodialysis. So basically his kidneys were so injured that they weren't able to adequately filter blood. And he needed a machine to do that for him for a number of days. In addition to that, he developed what's called a type 2 NSTEMI. This is very similar to a traditional heart attack, and that was due to overload, increased stress demands placed on the heart from everything else that was going on. He also developed seizures while he was in the ICU. When you're in the ICU for a prolonged amount of time, you are at increased risk for developing seizures, but we're also noticing from some recent studies that even just having COVID is increasing your risk of having seizures, and I'll touch on that briefly in just a moment. So additionally, he had a sacral pressure injury, and this would be expected from, again, prolonged ICU stay. If you think, the patient has a ventilator or a breathing tube placed in him, he's not getting out of bed, he's certainly not getting very good nutrition, if any, and so that's going to increase his risk for some skin breakdown. And then to top it all off, even after having COVID-19, after having all these different conditions, he developed a new onset hospital-acquired pneumonia. So basically, there's some organisms out there that take advantage of the situation. We call them opportunistic bacteria or opportunistic organisms. And in his case, because he had the ventilator tubing for a long amount of time, there's certain bacteria that are able to grow on that tubing, and after they replicate to a certain amount, cause a pneumonia for him. So just kind of touching on two big studies that came out over the last few months. In April, in the Journal of American Medical Association, they found that COVID-19 has a predilection for the ACE2 receptor. And what does that mean, or what's the significance of that in our case? Well, that ACE2 receptor is found in the lungs, the kidneys, the heart, and vascular tissues. So again, from looking back at his ICU stay, you could see that all of those organ systems were significantly involved. In addition to that, they also found that that COVID-19, there's elements of COVID-19 that pass the blood-brain barrier and that have central nervous system involvement. So again, based off both of those, based on our patient's presentation, that makes sense. Alrighty, so 38 days after intubation, our patient was successfully extubated. Prior to that, he had a tracheostomy tube placed and a peg tube placed. Basically, it's actually safer and less chance of infection if instead of having the breathing tube go through the mouth, that they place it over the trachea and they're able to maintain that for a longer period of time. And then in addition to that, like I was saying earlier, because he's in the ICU for so long, because he's not able to eat, because we can't really provide supplemental nutrition through an IV, he had what's called a peg tube plate. It's literally a tube that goes from the exterior of the stomach, and we're able to artificially feed him while he's still recovering. So 7 days after his admission, finally he was medically stable enough for discharge to acute inpatient rehab. So as you can see, that's nearly 2 months, quite an extensive hospitalization, and in over 1 month where he was in the ICU. All right, so what is acute inpatient rehab? So again, kind of touched on this a little bit earlier from the PM&R standpoint, but basically patients who suffered a traumatic injury or a debilitating disease with prolonged hospitalization, they're able to receive an intensive multidisciplinary rehab course with the goal of returning to home in the shortest amount of time. So, I talked about the rehab team earlier, but I really like this picture because this is really how it works. We have our team of therapists and other rehab staff, and we all sit at a conference room, at a conference table just like this one. We go through each different specialty, kind of go through what's going on with the patient how they're doing well, how they're not doing well, what adjustments need to be made, do any medication adjustments need to be made, those sort of things. And every single case is a patient-centered approach. So for me, that's fun. That's exciting. I think, I'm biased, but I think PM&R is probably one of the most team-oriented fields within medicine. And this is a large reason why. And the reason we do this is, we create a high-intensity focused regimen of rehab, and we try to do it in the shortest amount of time and minimizing the medical complexities that exist. Alrighty, so when I say medical complexities, this is kind of the new norm as far as a COVID-19 patient. This patient's on the ventilator right now, and we don't accept active ventilators, but they do come to us something like this, looking like they're tightly wound up in saran wrap, kind of. Again, this is the new norm, and as you can see, this patient can't go home. They can't get in and out of bed. They can't feed themselves. So as far as our approach, we put them in, any COVID-19 patient has to have 2 confirmed negative tests before coming to us. And we also put them in the isolation for 48 hours. Isolation isn't probably like what you think as far as a prison, but basically we have contact precaution, respiratory precautions. We don't expose the patient to other patients within the hospital or the rehab gym. And this makes sense. Our therapists are really the unsung heroes with this. They're getting up close and personal, working with the patients. So certainly we need to protect our staff. And we don't know, in transport if the patient might have picked up something or is carrying something. So, it's kind of a precaution that we take prior to really diving in and digging deep into therapies. All right. So as far as his initial days, our patient arrived with an elevated heart rate, which is tachycardia. Why was it happening? Possible different reasons that are attributed with that. Sometimes with individuals with significant deconditioning, we'll see an elevated heart rate, possibly because of his type 2N STEMI, because of his previous heart damage. But there's other issues as well. So it's an important vital that we keep an eye on. He also had increased oxygen demand. So when he came to us, he was requiring about 2 liters of oxygen continuously. And then in addition to that, not even a full day into his admission, he had a rapid response and became briefly unresponsive. So it occurred over a short amount of time, and we weren't quite sure exactly what had happened, whether or not it was a seizure or a vasovagal episode where basically the patient just passed out. Ended up contacting his neurologist and increased his seizure medication. And then, for a brief period of time, had no issues following this. Although 3 days into admission, again, another rapid response. Again, these vitals here are not very encouraging. So blood pressure 60s over 40s, this is very low. His oxygen saturation is getting worse. Previously when he came in, he was requiring 2 liters. Now he's requiring 5. And he's in the high 80s with oxygen saturation. To give you an idea, you and I are probably somewhere between 95 to 98% on just regular room air. So, this high 80s on 5 liters is definitely is much changed. He has that tachypnea, which I was explaining earlier. His respirations are about 20 to 24 minutes. And his heart rate's increased a little bit. When he initially came over, it was about 105, 110. Now he's higher in 110 to 130 range. So, okay. All right. So here's kind of a picture. This is basically what a typical rapid response looks like. You have all these different professionals and medical personnel around the patient, trying to figure out what's going on. And, with those vitals are not sustainable. You need to make pretty quick decisions and some pretty quick management with that. So, all right. So what do those vitals tell us? In large part, we're thinking infection, the low blood pressure, the oxygen being an issue. As far as potential sources, this is kind of what's going on in the back of our head. We need to know where the infection's coming from, because there's different types of infections in different areas of the body. And if we know where it's coming from, then we can properly choose the right antibiotics that we think are best going to manage it. So when he came to us, he had a Foley catheter. Basically, that's an instrument that helps him go to the bathroom without getting out of bed, just a tubing system. There, again, just like the ventilator tubing, there's certain organisms that like to grow within that Foley catheter tubing. And again, if given enough time and opportunity, can create a major infection. He also has that sacral wound. So, your skin is a major barrier in preventing other organisms from entering the body. And that's a major opening that he has that's open to, the outside world and potential for infection. But then also the lungs, I think that's a big one. And we know he had the COVID-19 infection. We know he had a subsequent pneumonia on top of that. So we know there's probably some residual fluid in the lungs and that they're already have some extent of damage to them. So in our initial workup, we got a urinalysis, basically testing the urine. This was negative. So kind of showing us that most likely doesn't have a UTI, most likely not related to the Foley catheter. Ended up getting a chest x-ray and it showed a right middle lobe pneumonia. So when we compared this to the one done at the outside hospital 4 days prior, it did not show, let's see if I can get my laser here. It did not show this, we call a consolidation right here. So again, just like the CT scan, you think about black is air, the whiter parts, these would be your ribs. And then any whiter parts in between that, we're looking at fluid. So, the right lung has three lobes, and this would be the right middle lobe here. So we can see there's definitely some fluid development there. We got some blood work related to that. It showed a mild elevation in his white blood cells, again, indicative of new onset infection. And then there's a new lab marker called a procalcitonin level, and this is specific to pneumonia, and this was also mildly elevated. So with all that in mind, we're pretty confident that he has, and again, in addition to the COVID-19 infection, in addition to the other pneumonia, now he has third pneumonia that's developed. With that, we consulted the pulmonology team. I was able to provide some further guidance, as well as some IV fluid and antibiotic recommendations with that. Alrighty, so again, kind of mentioned that. So the IV fluids and antibiotics, fortunately in his case, again, he came with the Foley catheter. He actually came over to us with a PICC line, which is a central line. Normally when patients come to us with those, we try to discontinue those immediately because they are a source of infection. But fortunately in his case, we ended up maintaining them. We ended up maintaining them because we knew it was an acute case. We knew he had an extensive stay. And unfortunately for us, that lucked out. So, immediately once we got our chest x-ray results, we immediately started him on bolus IV fluids, put him on a broad spectrum antibiotics, and we were able to administer those very quickly and also keep track of his fluids with the Foley catheter. So, kind of keeping track, it's kind of, from a simplistic standpoint, if you're running a lot of IV fluids, you can kind of keep track and see, is he dehydrated, how much is coming out of the Foley, and kind of manage your IV fluids from there. All right. So kind of mentioned this already. He was ended up being on a 7-day course of IV antibiotics, about 4 days of IV fluids. So basically, again, identify the problem. We had to act quickly. But also, and again, what I really like about rehab is, he had to get moving again. We had to get him in therapy. So I think, this whole string of events happened around 9 or 10 in the morning. You get your chest x-ray results back at around 11:30. You start the IV fluids and antibiotics at 12:30, 1 o'clock. You let him rest that afternoon, let him rest that night. And basically the next day, it's kind of like, all right, he's got antibiotics. His vitals are stable. It's time to resume therapies, because really that's what's best for him. He's deconditioned. He needs to get up, get moving around. Certainly we adjust according to that. We'll run his fluids at night, so they're not getting in the way while he's doing therapy. It's pretty hard to do therapy when you're moving an IV pole around with you, going up and down stairs or trying with a walker, with an IV pole. So we'll try to manage that at night. We try to do that around maybe meals. But main thing is, again, trying to get as much therapy as possible in a short amount of time, because we want him getting healthier condition and we want him getting back home. So midway course of rehab, started having some issues with orthostatic hypotension. So again, if you remember from a couple slides back, the COVID-19 does have a predilection for invading vascular tissues. Also, just expected, again, from prolonged hospitalization, prolonged time in bed, basically his vessels have gotten kind of lazy, if you will. So when the patient's sitting or laying flat, his blood pressure is normal, but when he goes to a standing position, it drops significantly. So that's very uncomfortable. He's feeling nauseous, feeling really dizzy, can induce vomiting. So the ways that we help mitigate that, one, there's some medications that we can use that help clamp down those vessels. We use both midodrine and fludrocortisone, which were both effective in his case. But the other one, which is very simple and easy to do, is we use compression stockings and an abdominal binder. So the stockings, you kind of like a tight pantyhose you put on your legs. A lot of times we put them on patients after an orthopedic procedure. But also the abdominal binder. And basically, the goal of what we're trying to do is try to minimize and eliminate that venous pooling, that blood that's just kind of sitting in the legs and sitting in your abdomen, and try to force that back up to your core and to your heart, and pump that to your organs, into your head. So through the rehab course. So if you remember from our image a little bit earlier, that, the patient coming in on the stretcher, not able to get out of bed, not able really to, even having difficulties getting to a seated position. Now he's what we call contact guard assist with ambulation using a front wheel walker. This is kind of what you see here. And then in performing showers, he's what we call standby assist. So contact guard assist, again, very similar to the picture here, where the patient is doing all the work. We just have a therapist. Therapist has their hand on the patient, provides a extra point of contact, helps with their stability and balance a little bit, in proprioception. And standby assist is really just the therapist is keeping eyes on the patient while they perform an activity, making sure they don't lose their balance, making sure they're able to execute that task effectively. And then most importantly too is, patients able to go from a sitting to standing position now asymptomatic. So they're not having those symptoms of dizziness and nausea, and they're able to do their therapies more effectively. So getting towards the end of our patient's rehab course, again, another rapid response. This time it was during speech therapy. Therapy noticed about a 10 to 20 second period where the patient was non-responsive. We attributed this to an acute seizure. Again, we increased the seizure medication and sent him up with an MRI of the brain following discharge, and this was all coordinated with his neurologist. Recent recommendations, literally a month ago, June 30th, the American College of Neurology came out, and they recommended that any patient who was admitted to the hospital with COVID-19, that at some point they would benefit from a MRI of the brain as an outpatient study. So, and I think that makes sense, given what we've seen, 2 possible seizures during his acute rehab course, in addition to a previous seizure during his previous hospitalization. So at the end of his course, 83 days, if you remember, 83 days from that March 20th presentation, our patient was able to be discharged to home at a modified independent level with walking. Basically, that means he's able to use a cane or a walker without any assistance. And this is the picture on the right. That's not him, but it's a pretty similar setup where we have, the staff all lines up in the hall. In our case, our patient's not in the wheelchair. He's, walking out with his walker. It's called a clap out, where once they get, they walk from the nurse's station to the doors, and we clap them out at the very end. It's a pretty neat experience. And again, when you think about when that patient came in, about 3.5, 4 weeks prior in the stretcher, couldn't even get out of bed, and now they're walking out of the building. It's a pretty powerful experience. So unfortunately, a couple of days after his discharge, he had an acute syncopal event during his physical therapy session at home. Ended up going back to the hospital, and just briefly. They gave him some IV fluids. They adjusted some of his blood pressure medicines to help maintain those blood pressures. Unfortunately, he did not have to be admitted. They were able to discharge him back to home. So when I saw him in outpatient clinic, and I brought that up with him, he admitted that he might have been going a little bit too hard in physical therapy that one session, and that's kind of what sent him to the hospital. And I kind of jazzed him a little bit about that. And he definitely was a trooper throughout his rehab stay, and that's large part why he did so well was always sticking with us. But right now he's independent at home with all ADLs and walking. He's walking his neighborhood about 1 to 2 miles a day. He says he still experiences some shortness of breath, some dyspnea on exertion. Basically, like if he's going upstairs, he notices that something's not quite right with his breathing. But then in addition to all that, he says his shoulder is a little bit tight. So for me, in my standpoint, that's a pretty good sign for me that, hey, the breathing isn't so much the priority. It's that he's got these tight shoulders. So I know he's doing pretty well in that regard, and ended up examining him and found that he had what's called adhesive capsulitis, or also known as frozen shoulder. And the great thing with that is the first line treatment is more physical therapy. So obviously he can benefit from that, and he'll come back in September, and I'll reassess him at that time. So a couple outside cases. This is a gentleman, 29-year-old nurse practitioner, just outside my hometown in Dunwoody, Georgia. And he ended up being intubated, as you can see here in the bottom right, for a period of 4 days. And another case here. This is a gentleman, 43-year-old nurse from San Francisco, California. He was hospitalized for 6 weeks. 4.5 weeks he was intubated with sedation. And in that course, he went from 190 pounds at admission to 140 pounds at discharge. So, why do I bring up these cases? I think it's important. I think that everyone is cognizant of what's out there, and that, these two gentlemen, I go back here, I think they're doing something right. I think, you can make a pretty good argument that they're pretty healthy, pretty good shape. And despite that, with this virus, it's still significant that everyone's vulnerable, and there's an element of significant deconditioning. So some closing thoughts here. Again, our patient's doing very well right now. Despite that, there were many moments, including in inpatient rehab, where he was near death. Overall, he's a relatively healthy gentleman with minimal medical complexity. I think he had some high blood pressure, high cholesterol, and some diabetes, which was well controlled and on oral medications. So, when we compare that to a lot of the other patients that we typically see, overall, a pretty healthy gentleman. I think he was in his late 60s. So anyhow, definitely doing better. And I think overall, from a healthcare standpoint, I think we're getting better at managing these cases. I think just 2 weeks ago, there was a major study that showed ICU mortality has decreased from 60% to 40% in May. So, that's definitely better. But 40% is still double that of any other viral pneumonia that, where patients have to be admitted to the ICU. So, yeah, we're getting better at it, but it's still definitely significant with a significant mortality rate. So, again, from what I mentioned, that first slide, we're just bombarded by COVID-19 from the news, from politics. Me personally, I found that I had to limit my reading on COVID-19, even if it was for a medical standpoint. And, I tried to focus my attention on what I thought was the highest yield and what would help me in my practice in treating patients. And I think that's important to do too, is again, there's so much information out there. As my dad would always tell me, analysis without paralysis. So I think it's important that we know that it's out there. I think it's important that we take the right precautions in mitigating that. But certainly, I think, we need to live our life and proceed with things to the best of our ability. And here I just included a quote from Dr. Fauci, and I think this definitely holds true. It's not a sprint; it's certainly a marathon. We're going to get through it. It can't last forever, and that the people, but I mean, I know we're all affected in a different way, shape, or form, in some way, and no matter how we're affected, we're all going to get through it together, and eventually it'll pass. All right, so because this is a Stetson talk, I don't think I'd be able to complete this presentation without two major shout outs to two special individuals who were very important to me and helped challenge me and believed in my abilities and kind of dared me to push the limits. Dr. Price and Dr. I. Don't think I need to go into a whole lot of detail with them. I think, if you just Google their accomplishments, their published studies, I think a lot of that speaks for itself. But the main point I highlight, these two people, definitely very close mentors during my time at Stetson, is that I think if there's some good that can come from this pandemic, it's a reaffirmation that there's a growing necessity for individuals to pursue the sciences. So, we know that there's somebody out there that's going to cure COVID, that's going to cure cancer, that's going to come up with life-saving drugs. And I just feel comforted that these two individuals are still there at Stetson, molding young minds and helping prepare us for that future. So these are some of the references I use for the presentation, fairly extensive. But at this point, just want to open the floor and open any questions that you guys might have.
Yeah, Bill, thank you. This was great and really, really eye-opening stuff. And we did have one question dropped in the chat earlier from Ruth. She just asked the general mortality rate for ARDS that we showed earlier. Can you explain maybe why that's so high, that general mortality rate?
Yeah, so there's quite a range on that. It's something, and again, I'll do my best to explain it from a PM&R standpoint. It's something we've really struggled with, that we don't have a true understanding. We know there's certain conditions which precipitate it, which cause it to occur. It's very difficult to get a handle on it. It's kind of like a overreaction of the body's own immune system. So it continues to propagate it. The body thinks it's healing itself, when in actuality it's actually causing some increased damage. So the big thing with that is, when you have that kind of high degree of inflammation, high degree of fluid, one, it creates significant damage to the lungs, and two, if we can't create oxygen exchange, there's really, even with a ventilator, there's very little we can do beyond that. So, once the lungs have significant damage, it's really difficult to take a step back and help them recover from that.
Yeah, so again, as Bill mentioned, and I'll say it again, if anybody has any questions or comments, feel free to drop them in the chat box now. I'm taking a look at that, or turn on your microphones and your cameras if you'd like. Feel free to ask away. If anybody has any questions, I'll give it a minute. Sometimes it takes the chat a little bit to load. But one thing I was going to ask, I'm glad it was in the presentation too, is that I was going to wonder how long that patient was in the hospital for and how long that took, that 83 days. That's just, I can't even believe it. Like that's.
Yeah, that's extensive. And that's kind of neat part. That's why we have acute inpatient rehab too, is that, from the organ standpoint, we get all those fixed and function, and, thank God we have modern medicine for that. But, if you can think, when you're really sick, if you've been in bed for a handful of days, it's not like you can just get up and hit the ground running. You need to regain your strength, and, that's kind of what we're here for. So.
Absolutely. And we did get another question come in here from Ruth again. Has there ever been an instance where your team had a difficult time choosing a recovery track based on complications? If so, what were the methods that were used to find the best option for them? Yeah, so
certainly, I think there's part of PM&R, you're in a large part just being a physician, you're constantly dealt with situations adverse situations where you need to come up with innovative solutions. Classically with this whole outbreak is With the acute rehab facility, we can do chest x-ray in-house, we can do a lot of labs, but a great way to look at the lungs and to see fluid is by doing a CT scan. So we had a gentleman that came to us with a lung transplant, and again, very similar story, been in the hospital for, I want to say, a little over 3 months, and came to us, and we had some concerns that he might have been developing a pneumonia, and we were working really close with the pulmonology team. And at one point, I think the pulmonologist suggested, well, we should get a CT scan for, to get a better look at those lungs. And certainly agree with him on that standpoint. But if, you kind of have to think a little bit outside the box there, because, if we have to send our patient to an outside facility, one, if he has a lung transplant, you have to put him on immunosuppressive drugs, which is going to increase his risk for developing a COVID-19. On fresh transplanted lungs, that would be catastrophic. And two, if we're going to put him through a CT tube, we have to believe, or at least assume, that there's other individuals with suspected COVID-19 that are going to go through that same tube. Obviously we would hope that that tube's getting clean, that area is getting clean, but nothing's perfect. Those patients, I get on the elevators every day, and those same patients I got to go for imaging have to get on that same elevator that I'm going on. So, we do the best that we can, but in this patient's particular case, we ended up deciding we would just do a couple chest x-rays, and as long as clinically and vital wise, if those were doing well, that we wouldn't do the CT scan until a later date. So, but good question.
Yeah, great question, Ruth. And I'll leave it open for another minute or two. If anybody has any final questions, to drop in the chat, or feel free again to turn on your microphone if you want to ask a question. But while we wait for any final questions to come in, thank you to everybody again for joining. And Bill, thank you for taking the time to do this with us. This was really great and really informative.
Absolutely.
I'll give everybody just another minute here if they have any questions.
Actually, I have a question. This is Nancy. Bill, this one patient you're talking about with rehab from COVID, is that, was that his choice to select your facility, or how does that happen that there was only, you've only had one patient, or is that just you personally, your team's only had one patient?
Yeah, absolutely. Great question. Multiple different factors associated with that. So right now I'm doing residency in Toledo, Ohio. So in our particular area, there's 3 inpatient rehab facilities within Toledo. The hospital that he came from was 15 minutes down the road. So there's a couple different factors, obviously one being location, 2, insurance has to accept. 3, and the other interesting point was at this time, so we're about an hour from Ann Arbor, hour from Detroit, Michigan. And all of their inpatient rehab facilities were converted to COVID-19 units. So they were on a diversion too, kind of the other COVID patients and other rehab patients to our facility based off of that. That being said, I think, this is, my personal, my personal experience, and one of the patients I treated. I think to date, we haven't had a ton. I think we've had 7 that have come to our facility specifically because they went to the hospital because of COVID-19 first, not because, of course there's patients that maybe they went for a heart failure exacerbation or something, and during that hospitalization developed COVID-19 in addition to that. But specifically, I want to say we've had 7 patients so far from a rehab standpoint. So I just thought this patient in particular, because of his extensive medical course, I thought it was pretty interesting. And not everybody's like that. Some patients, they do really great. I think by and large, we're seeing significant deconditioning. And again, that's expected when, you have that extensive hospitalization.
Yes, thank you. That was a great question, Nancy. And I think that is all the questions we have. So again, thank you everybody for joining. Thank you, Bill, again for taking the time and for all the great work that you and your team are doing up there. This is really, really great stuff, and we really appreciate all the work you guys do.
Yeah, thanks, Alex, and thank you guys. Sorry for the little technical difficulties in the beginning, but I appreciate you joining on, and I hope everyone's doing well, your families are doing well. And to my few friends in Pittsburgh, I just want to shout out to them. Thanks for joining, and go Steelers.
I'll allow the Go Steelers. I'll allow it.
All right.
They're good. All right. Thanks, everybody. And thank
All
you.
right.
Have
Thank
a
you,
good
Alex.
night, everyone.
Thank you.